So I think in order to understand, what exactly is a partial or sometimes called a unicompartmental total knee, you kind of had to briefly understand the anatomy. So the knee, we generally think of it as three separate compartments. We have a lateral, patellofemoral, and a medial compartment. And these are two images that are showing a graphic representation of these compartments. Additionally, this image on the left shows a little bit more. It shows the patella sitting over the patellofemoral compartment. And it also shows your meniscus, which are the blue bands, and then your collateral ligaments, which are the pink structures. And they're very important for how the knee functions and deciding if you would be a good candidate for a partial knee replacement. So along with that, a total knee replaces just that. It replaces all three compartments. And so in this illustration, if you look on the left, we see a native knee, and where it should have nice, clean, smooth, kind of pink-white cartilage, what we see is that's been worn away. We start to see bone spurs on the periphery of the bone and cartilage junction. We actually see that the cartilage has been worn through, and we see this kind of angry red bleeding bone underneath, and that's what osteoarthritis looks like when you open up a knee. So in this situation, this patient has wear on all three compartments, as you can see here. And this is what it would look like after a total knee was completed. And so in this scenario, I think a total knee would be the ideal option for this patient. However, in situations where a patient has only wear or osteoarthritis in just one compartment, there's other options or kind of a minimally invasive surgery that can be done, and that's where the partial knee or the unicompartmental knee comes from. So in this illustration, on the left, we see what is isolated medial compartment osteoarthritis. I don't see any wear on the lateral side or on that patellofemoral compartment as well. And we see what it would look like from a graphic illustration standpoint after a partial knee has been completed. So we can see that they replace part of the bone off the tibia, and they also replace part of the bone off the femur. And somewhat hard to make out, but you can see the kind of plastic bearing or polyethylene bearing that goes in between the two pieces of metal. So along with this, just as there's three different compartments to the knee, there historically is three different types of partial knees that can be performed. The most common, overwhelming majority, probably 80–85% of partial knees are what's considered a medial compartment or the inside of your knee. But you also can do a patellofemoral arthroplasty where you just focus on that patellofemoral joint and you would replace the undersurface of the patella. And then probably the most rare, making up less than 5% of partial knees, is a lateral compartment uniarthroplasty. And that really is just based off the normal and characteristic pattern of osteoarthritis progression in the world. It generally is medial or medial patellofemoral compartment osteoarthritis, and then isolated lateral compartment arthritis is relatively rare. So along with that graphic representation, here's actual x-rays of what some of these different surgeries would look like. So starting on the left, we see a medial compartment arthroplasty. In the middle, again, a patellofemoral arthroplasty, and then a lateral compartment arthroplasty. I think for people who are not familiar with the anatomy, this extra bone that you see here on the lateral or outside the leg, that is the easiest way to identify which side of the leg we're looking at. Are we looking at medial or lateral? Because the fibula is a lateral structure. So what are some of the indications for a partial knee replacement? And what am I looking for, in the initial kind of pre-op assessment, or when I get referrals from primary care doctors, physical therapists, or other healthcare providers? Ultimately, we're looking for patients with end-stage osteoarthritis of the knee, and in this case involving a single compartment, again, either medial, lateral, or patellofemoral. Additionally, patients need to initially fail conservative measures such as NSAIDs, over-the-counter anti-inflammatories, bracing, compression sleeves, or hinge braces. I think weight loss, we know is pivotal to patients minimizing their knee pain both before surgery and recovery after surgery. Often physical therapy can be beneficial. And then I think as we start to get more invasive, we can do injections, whether that's cortisone type injections or some of the hyaluronic acid injections that we do as well, or that's also known as viscosupplementation or gel injections. Additionally, this pain needs to be advanced enough that it's really beginning to interfere with the patient's sleep and their abilities to perform the activities of daily living. And this is when we think that patients are becoming more of an ideal surgical candidate. So when you have a hard time going to the store, or you don't want to go out and go for hikes or walks and do things with family and friends, or you're not able to do the sports or other activities that you enjoyed previously, these are when patients are really becoming ideal candidates, I think, for knee replacement. So what are some contraindications of a partial knee replacement? And I think that has varied in the literature some, and it's varied over the last couple of decades as we've kind of refined our surgical technique. We've had more long-term outcomes to see how patients do. First and foremost, again, it needs to be, or it can't be multi-compartmental disease. So again, it needs to be arthritis in just one area of the knee. Patients clearly do better if they have an intact and functioning ACL. So patients with previous ACL injury or an ACL reconstruction that has failed would not be a good candidate for this procedure. Patients that are morbidly obese historically have not done as well in the literature and are much more prone to have tibia fractures occur when they have a partial knee replacement. Additionally, patients with inflammatory arthritis, such as rheumatoid or psoriatic arthritis, they generally are not ideal candidates for a partial knee replacement, in part because generally they have more of a diffuse and global arthritis pattern, but also their bone generally is not nearly as strong, and they're much more likely to have fractures as well. Patients that have preoperative flexion contractures greater than 10 degrees are probably not an ideal candidate for a partial knee replacement either, because in doing the minimally invasive partial knee, we're not able to make additional cuts or releases in order to get a patient who has a flexion contracture in order to get their knee completely straight. Similarly, if patients have a really fixed, rigid valgus or varus deformity, in general, they're not ideal candidates either. And so in this picture, we see a patient with a big valgus deformity, or also known as knock knees. And these patients really need more of a total knee, because you really need to address all compartments in order to get that knee to balance, and particularly to get that leg straight in the future. And so when doing a partial knee, just as it is, minimally invasive and it spares some of the other compartments, your ability to make corrections are minimized because of that. So in talking about this, what are the benefits of a partial knee replacement, and specifically, what are these benefits over your standard total knee replacement? I think first and foremost, there's a significantly smaller incision. With that smaller incision, not only is there cosmetic benefit to that, I think there's less pain associated with it due to the smaller incision, and due to the fact that we're removing less bone and we're leaving more of your native bone in place. Along with that, as you can expect, there's significantly less blood loss associated. So the transfusion rate is much, much lower than in our standard total knee patients. And in a healthy patient who's been optimized preoperatively, transfusion after a partial knee is almost unheard of. Along with these things, their patients clearly have a shorter hospital stay. Patients are going home the same day. I haven't had any patients not go home the next morning. And so I think patients are able to get back home much easier in their own environment, and they recover nicer because of that. What allows some of these improvements and less hospital stay, quicker recovery? Certain activities, there's clearly a better long-term result in stair climbing, and patients who were using assistive devices such as canes and walkers preoperatively, literature clearly shows that a lot of these patients do not use these devices postoperatively. So along with patients just having an initial quicker recovery, being able to have less pain, less bleeding, and to go home sooner, what are some of the long-term benefits? I think when thinking of knee replacements, you do need to consider the long-term implications of surgery in general. The literature clearly shows that partial knee replacements have a minimum about 9 to 10 degrees more flexion than a total knee. And I think that really helps patients who are very active, who do yoga, or whose jobs require squatting and things like that. They definitely can benefit from this. There's clearly a lower infection rate. It has less than half the the infection rate of a standard total knee. And along with that, there's a lower DVT rate. So aggressive blood thinners are generally not necessary. If patients are on blood thinners preoperatively, we normally can resume those faster if they need extra protection for their heart or things like that. And I think all of these things go together just to have a higher patient satisfaction, higher outcome scores. Often there's a study or outcome study called the forgotten knee score, and partial knees clearly excel in this area. So much to the point that a patient will have a partial knee replacement, often kind of forgets that they ever had surgery or had a problem with that knee, and normally their normal knee becomes more symptomatic. Why is that? I think it's kind of multifactorial, but I think it does have to do with the fact that when doing a partial knee, whether that's medial, lateral, or patellofemoral, we're able to keep the patient's native ACL and PCL. And whatever compartments we're not changing, we're able to keep that native anatomy as well. And we know that because of that, the knee feels more normal. One complaint we get in patients sometimes after a total knee replacement is that the knee just doesn't feel normal. And that's understandable because we have replaced a lot of your normal anatomy and structures with special types of metal or polyethylene. And so it's normal for the knee not to feel like it did before. But with partials, I think because we are able to retain so much of the native knee, patients truly can forget about it, and they are not fixated if they've had a knee replacement. And by leaving these contralateral meniscus, relieving the ACLs and the PCLs in patients, they have increased proprioception and better kinematics, meaning that the way that the knee articulates and bends is much more normal. And I think that all these things come together to provide kind of a superior outcome and higher patient satisfaction. One subset or sometimes comparison that patients have, especially in the younger patients, or referrals from physical therapy, should they have a partial knee replacement or something called a high tibial osteotomy. Specifically, what this is when patients have bowing to their tibia. In this setting, in the picture on the left, the patient kind of has bow legs, where his legs bows out, and that deformity is occurring through his tibia. Some doctors can do a surgery to kind of straighten and align that bone in hopes of better balancing the knees and more evenly distributing the weight distribution of the patient. And so you can see where they've done this on the right, where they've actually kind of cut and opened up the bone and put this plate and a metal wedge in there. And the legs do look much more anatomical, they're straight, and the patient probably will do well. And this is one way to address kind of unicompartmental arthritis, especially when there's a deformity, but the other option that I'm more of a fan of is to do a partial knee replacement. And so a few of the differences between those is when you have an HTO or a high tibial osteotomy, the incision is normally much larger. As you can see, that's a pretty significant plate that must be put in. Patients are generally non-weight bearing anywhere from 8 to 12 weeks after surgery. Whereas with a partial knee replacement, you're walking immediately after surgery, hopefully home the next day, and no weight bearing restrictions. The literature clearly shows that in the short term, there's less term complications, less infections, less pain associated with a partial knee replacement. And then if in the future, whether this is 10, 15, 20, 30 years down the road, if the patient develops arthritis in the other compartments, it's much easier to revise a partial knee replacement to a total knee replacement than it is to go from a high tibial osteotomy, where we must remove all the plate and the screws in order to perform the total knee. So some disadvantages of unicompartmental knee replacement. There is always the possibility, especially in patients who are young, that they could develop adjacent compartment osteoarthritis in the future. We don't see that when patients are older, in their 60s or 70s, and they have isolated medial compartment arthritis. Those patients are probably less likely to develop adjacent compartment arthritis as long as the uni is put in correctly. But in a patient who maybe from prior trauma, who has developed arthritis at a young age, they may be at an increased risk of later developing some arthritis and later developing pain and needing conversion to a total knee. Along with that discussion about the legs being kind of bowed or crooked, When we're doing a partial knee, I cannot substitute for your collateral ligaments. And so that is one weakness of a partial knee compared to a total, is that I need you to have an intact ACL, PCL, LCL, and MCL. Again, as we mentioned earlier, especially in patients who are obese or those who have very poor bone quality, there is an increased risk of a tibial fracture. And I think to be honest, one must say that a unicompartmental knee replacement is technically more demanding than a total knee replacement. I think that's why surgeons, do additional training such as fellowships to learn how to properly perform this procedure. Additionally, I think we have increased accuracy and precision with the introduction of navigation and robotics into our kind of surgical armamentarium. And so I'll kind of talk on the ability of introducing some robotics in unicompartmental knee replacement as well. So here's a patient who came in. This was a relatively young male with isolated medial compartment osteoarthritis, really in both knees. So in this X-ray to the left, where you see the two knees, he has this in both his knees, both his right and left knee. And you can see here that, again, it really is narrow and kind of more symptomatic on the inside or the medial aspect of his knee. He has a good joint space preservation on the lateral aspect of his knee. And you don't see any, significant osteophytes or things like that. Additionally, in this far image, we look at his patellofemoral joint from the side and see very minimal arthritis there. And specifically, the patient had no complaints of anterior knee pain that would be of concern. I also use this lateral X-ray to evaluate the wear pattern on the tibia in patients who have maybe unknowingly torn their ACL and PCL. I sometimes can detect, new or kind of varying wear patterns on the tibia in that case, and can make a decision preoperatively. So one thing about the Stryker Mako, one of its big benefits, along with some preoperative imaging, is it allows preoperative planning and also intraoperative planning. So here is a graphic representation of this patient's bones that were achieved by getting a preoperative CT scan. And then using this computer modeling system, we're able to accurately measure and predict what size implants we think we need before surgery, something that's generally done during the time of surgery, but we can do this beforehand. And we can also actually move and adjust the implants where we think they would sit ideally on the bone. And then it can give us results. So in this setting, we think that the patient should have flexion up to 146 degrees, which is more than the average patient has even before surgery. We're going to leave some slight varus deformity intentionally to protect the other aspect of the knee, and then we can set our rotation. This is really powerful to help make a preoperative plan and then be able to kind of reproduce this intraoperatively. Again, this is another kind of intraoperative planning to where I'm able to adjust the femoral component, and I can actually kind of superimpose that on the bone with the CT scan here, and then the 3D model to, again, adjust this in all these different planes. I can flex and extend and internally and externally rotate, take it anterior and posterior, just so I can place that just where I think is the ideal patient, the ideal position for that patient's anatomy, ultimately to maximize their postoperative outcome and the longevity of this implant. And this is what it would look like after surgery. So you can see on the AP and on the lateral how we've replaced the osteoarthritis, or the area that was kind of bone on bone. We've replaced it with this new implant, and then it lines up nicely with the bone, and it shouldn't have any impinging through flexion and extension. Additionally, here are just a couple more X-rays of some additional patients that have been completed, or we have just replaced the isolated compartment that was diseased. We've kept the leg in its kind of straight and neutral alignment. Don't see a lot of arthritis in the lateral compartment or in the patellofemoral joint. We've maintained the native tibial slope, and the overall rotation and posterior offset of the femur is maintained. Additional X-ray of a patient. This patient was a little bit larger. So some of the initial guidelines talked about, patients being under 82 kilometers, and that's ultimately been expanded on as we've better understood partial knee replacements and how to put these in, that we can put these in larger patients or in stocky athletic males or females, but there are some limitations. And that's the conclusion of my presentation. Thank you for listening. If we have any questions, I invite you to enter them into the chat.
Thank you, Dr. Poole. As you guys are putting some questions in the chat box, just I'm going to let a few come in there real quick, Dr. Poole. I'm just going to let them know of a few things. All the information from this presentation today will be emailed to you, the recorded presentation along with any